having a presentation from Dr. Daniel Wilkie, who will be discussing disruptive behavior treatment progress as a function of practices derived from the evidence base for disruptive behavior and depression. We also have the pleasure of having a variety of folks on the panel, including uh, Mr. Adam Wyland and Reggie Ching. We will be doing introduction. I'll be sharing their bio sketches at the end after Dan's presentation, if that's okay. And in terms of housekeeping, for those of you that are interested in social work, continuing education units or credits, as a friendly reminder, whichever email you use to register for today's roundtable, please be on the lookout for a feedback survey to that email that we'll be sending out. And if you've received those, I mean, if you signed up, as a friendly reminder as well, CEUs are based on both your time in the webinar today. We're looking for at least a 90% time in the webinar today, and your completion of the forthcoming survey. So please be on the lookout for that survey on email. Also, at the same time, if you have not signed up for CEUs, we would greatly appreciate you fill out the survey, just broadly speaking anyways. We're always looking for feedback. With that said, quick introduction of Dan before we turn it over to Dan. In terms of setting the larger picture, Dan will correct me if I'm wrong, but I'm thinking his total presentation will be around 45 minutes. He's going to stop at around the halfway point within that 45 minutes, 25 minutes for questions, comments, and then again at the end for questions and comments at the end. Then we'll be turning it over to the panel and doing formal panel introductions at that time. So regarding Dan's introduction, Dr. Wilkie is a postdoctoral psychology fellow at the Children's Hospital in Colorado. He recently received his doctoral degree in clinical psychology from the University of Hawaii at Manoa. A little bit more about Dan is that during his doctoral training, he previously worked with CAMD in a variety of ways through the Center for Cognitive Behavioral Therapy at UH Manoa, including conducting research with CAMD data, as well as serving as an intensive in-home therapist and evaluator for our system's initial mental health evaluations. So without further ado, if we, I guess, well, yes, there's no clapping in the webinar. Dan, I will give you a solo slow clap, just for you. Oh, there's Reggie. Oh, look at Adam. Everybody's clapping, and all the other 56 people are clapping too. Dan, you just can't hear them. Just rest assured they're clapping though. Okay, so without further ado, Dan, take it away.
All right, thank you, Dr. Nakamura. So yeah, today I'm going to be presenting on some of my research, which looked at disruptive behavior treatment progress as a function of practices derived from the evidence base for disruptive behavior and depression. I'm just going to cover a bit of the agenda for the day. So like Brad said, I'm going to talk quite a bit about the background that led to this study. So some of the research findings before my study itself. At that point, we will stop for questions a little bit just to discuss. I think there's quite a bit to get through. And then I'm going to talk about the study details, some of the results, and then some of the considerations that you all might take away from that. I'd like to just acknowledge everybody that gave their support throughout this process, including CAMD, PracticeWise, my dissertation committee, and many of the different students that gave feedback and support. So to start with just some background on disruptive behavior. So disruptive behavior problems, broadly defined, are behaviors that violate the rights of others and fail to conform to norms or authority figure expectations. When I talk about disruptive behavior disorders today, I'm going to be referring specifically to oppositional defiant disorder and conduct disorder, as well as the other specified disruptive behavior disorders. So there are other disorders that are in consideration, and the DSM has kind of changed this category over time, but these are the three that I'm really referring to as I talk about this today. Disruptive behavior disorders are pretty prevalent in youth samples. So in the broad population, about 5 to 9% of youth meet criteria for some kind of disruptive behavior disorder. And they're associated with all sorts of negative outcomes. So things like higher mortality rates, higher incarceration rates, lower relationship satisfaction, job performance, societal costs, like disruptive behaviors just have a lot of different things that aren't too great for both the people who have them and for society in general. In community mental health, disruptive behavior problems are the most common reason for referral. So over 4 in 10 youth in community settings meet criteria for either ODD or a conduct disorder. And that's just the youth that actually meet criteria for one of these two diagnoses. So you don't need to have one of these diagnoses to have problems with disruptive behavior. So almost half of youth meet for one of these two, and then there's very likely more that have kind of sub-threshold disruptive behavior problems. These behavior problems are highly comorbid with, anxiety, mood problems, trauma, ADHD, and they have many different causal factors. So when you have two kids with disruptive behavior, they're often coming from very different backgrounds. They often have different behavioral problems themselves. And so the treatment might look a little different for those two kids. But I think a common feature for kids with disruptive behavior is that there's often this negative parent-child interaction dynamic happening at home. So disruptive behavior problems have traditionally been considered as part of this so-called externalizing developmental track. And for those who might not be aware, in mental health, diagnoses have been kind of broadly categorized into externalizing or internalizing problem. This doesn't cover every problem in the DSM, but many are sort of put into one or the other. And with these externalizing problems, the idea is that it's people kind of acting negatively on the environment outside of themselves. The traditional thinking of this developmental track is that it kind of follows over the course of youth development with different presentations of problems. So traditionally, this was thought of as like, okay, ADHD starts in toddlerhood, that kind of manifests into oppositional behavior in preschool, that then can turn into conduct problems in elementary school and middle school, then into substance use problems in adolescence, and then antisocial personality disorder as an adult. And there is quite a bit of comorbidity here, like about half of kids who meet criteria for ADHD also meet criteria for ODD. About 30% of kids who meet criteria for ODD will meet for conduct disorder at some point in their life. And then roughly 4 in 10 who meet for conduct disorder will meet for antisocial personality disorder. Again, these are according to specific studies, so these numbers aren't definite by any means, but there's high comorbidity here. And I think it's notable that a majority of these youth don't actually go into that next stage of development. So for the most part, like a 3 in 10 who meet for ODD will meet for conduct disorder, but that also means that there's about 7 in 10 who don't then meet for conduct disorder. And I think this is especially notable because there's emerging research in the last 10 years that's really looking at irritability and oppositional defiant disorder and its comorbidity with depression and internalizing problems. So to talk about this, I need to talk a little bit about the criteria for ODD. There's 8 symptoms in the DSM for oppositional defiant disorder, and they've been broken down into 3 factors. 2 of those factors have been shown to predict different comorbidity. So the argumentative symptoms, those are symptoms like often arguing, defying breaking rules, purposefully annoying people. Those have been found to predict externalizing comorbidity. But these irritable symptoms, which are like throwing temper tantrums, getting angry easily, often being angry, have increasingly been found to predict internalizing comorbidity. Irritability, just as a symptom, is pretty interesting. It's defined as just the low threshold for the expression of anger. So people who have problems with irritability just get angry a little more easily, and so they're angry more often. And I think it's a really interesting symptom construct, and it's getting more and more kind of research focus because it's really found across many different problem areas. So especially for youth, not only is it symptomatic of ODD, but it's a symptom in the DSM for major depressive disorder, generalized anxiety disorder, disruptive mood dysregulation disorder, and dysthymia. So it's not just found in externalizing problems, it's actually found a little more in internalizing diagnoses. So that kind of leads to this picture of ODD as maybe a diagnosis that isn't purely externalizing as was traditionally thought, but kind of straddles the line between externalizing and internalizing comorbidity. So I picked out a couple studies that I just find interesting. There's more research out there, but I just want to cover a couple. One study found that childhood depression actually predicts adult depression less than ODD in childhood. So kids with ODD are more likely to have depression as adults than children who have depression. Another study found that every youth that they looked at in this study that had severe depression also had moderate or severe oppositional symptoms as kids. So there's something going on here where like some of the most severely depressed people had oppositional behavior problems when they were younger, and it really seems to be predicting depression in adulthood. So given, this increasing story of comorbidity between ODD and depression, it leads to some questions about what are the treatments for both of these? Like, are they treating the same thing? How different are they? And then how does that play out in different settings? So I'm going to start by talking about treatment for disruptive behavior. So it sort of breaks down by age group, which you'll see when I get to my study, which treatments are considered evidence-based. So for pre-adolescent children, the standard of evidence-based treatment is parent training. So it's called parent management training, behavioral parent training. And the idea behind this kind of treatment is really just to change the pattern of reinforcement by working with the parent and having them be the one kind of doing that consistently at home. So therapists who take this approach will focus a lot on promoting more positive behavior through things like praise and rewards for what they want to see more of, and then removing reinforcement or enacting some kind of punishment for negative behavior, for those disruptive behaviors that they see. So that's things like actively ignoring or timeout. For adolescents, the focus is still pretty heavily on parents, but therapists often focus more on systems more broadly. So they consider like social, ecological, and environmental reinforcement, as well as just kind of parent-delivered reinforcement. And these are treatments that include things like multisystemic therapy or functional family therapy. There are some individual treatment approaches for disruptive behavior, but they are less supported in the evidence base right now. These treatments focus on working with the youth with disruptive behavior, usually on some kind of combination of problem solving, social skills, and cognitive restructuring. But even for these treatments, something that I found interesting was that some studies suggest that parenting practices still predict response to treatment. So even though the treatment isn't involving parents at all, kids who have parents who are maybe not doing the best behaviors at home are still not responding to this individual treatment approach. In contrast to this sort of parent-focused approach for disruptive behavior, depression treatment really focuses heavily on the individual. The evidence base for youth depression treatment is only really there for adolescents. And the two well-supported treatments in the literature are cognitive behavioral therapy and interpersonal therapy, with a focus on working with the youth to change how they're thinking, what they're doing, and how their relationships are going. And then for pre-adolescent youth, there really isn't any well-supported treatment. I think the most recent review I saw categorized cognitive behavioral therapy as possibly efficacious. So it just doesn't have that level of evidence-based support that it does for adolescent youth. So these two treatment approaches are pretty different from each other. And that leads to some questions about how treatment settings might impact these approaches. And in order to talk about that, we kind of need to talk about how this research is done and what different treatment settings look like. So I'm going to start by talking about randomized control trials a little bit. So for those who might not be as aware about like what a randomized control trial is, I'll try to be really brief with the summary. The idea is it's kind of adopted from the medical model of comparing like an active arm of treatment to some kind of comparison group, with the idea that this is an experimental design. We're looking at causality. We're really determining, is this treatment efficacious for this problem compared to some kind of comparison? And the focus is really on control in that kind of setting. So it's kind of structured in a way where you want therapists to be doing certain structured things so you can say what happened in this study and you can make a claim about the results. This is generally what is used to inform the evidence base, and it's a bit more of a pipeline of this kind of research than being implemented in practice as opposed to vice versa. There is still some, like information gathered from practices that does inform treatment, but when we're talking about applying evidence-based treatment, we're talking about, using these studies and trying to apply them across different treatment settings. In the literature, the comparison group is often broadly phrased as usual care. The reason I put this term in quotes is there's not really a clear definition for what usual care is. Oftentimes, it's community mental health care, but some studies, usual care means no treatment. Some studies, it means waitlist control. So there's no definition of this term usual care, but I'm going to be using it because that's how the literature refers to it. And I can't really make claims more specifically about community mental health care, for example. So yeah, these two settings are different in a few ways. It's still unclear how this research is translating to usual care settings. And there are a few reasons for that, just because they're so different from each other. So I'm going to go over a few of those differences. Randomized control trial studies, they use different kind of participants than the people who are seeking treatment in community settings. So one study found that only 1 in 8 randomized control trial participants were actually treatment seeking or referred to treatment. So they might be using kind of more convenient samples or people who are signing up for advertisements or surveys to recruit for this study. The same study found that about 1 in 5 of the clinicians performing the research treatment were people who clinically practice as a part of their day-to-day life. So most of them are not necessarily treatment practitioners on a regular basis. They're doing it more for the purposes of this study. Randomized control trials often exclude people based on comorbid problems or complexity. And people who drop out of treatment typically aren't included in the final analysis for understandable reasons, because you don't have a full collection of data on what happened for them. But they did drop out of treatment, and it's just something to consider that there were people participating that didn't actually finish. There's a few other things here. Randomized control trials, they're often done in university clinics. They're often using structured manuals. They're often performed by highly supervised and trained therapists, again, with this focus on we need to control this study so we can, do science in this way. But maybe that is taking it in some ways kind of further from what treatment looks like in some of the clinical settings out there. In contrast to that, in usual care, therapists often report feeling overwhelmed by their caseload, and there's a high turnover rate for therapists. So that's just touching again on some of these pieces of data. I can't get into all of this information, but these two settings and the therapists involved are quite different from each other. And maybe more important in my mind for this study is that the clients and families are quite different from each other also. So usual care clients, some studies have found they're less white, they are older, they tend to be more female, and they tend to have more comorbid diagnoses than randomized controlled trial participants. And then the parents and families are more stressed. They have more mental health problems of their own. They tend to have lower socioeconomic status. They tend to have fewer social supports. They have more marital and family problems. And the reason I go through all of those kind of bullet lists is all of those have been found in one study or another to also predict poorer response to treatment. So some of the ways these populations are differing from each other are also predictive of not responding to treatment, which again leads to some questions about like how effective are these treatments in some of these settings or with some of these families. So I want to give a quick summary so far because there's sort of a few moving pieces here. So disruptive behavior problems, it's a major concern in community settings, increasingly found to be comorbid with depression, especially through irritability and ODD. The focus of treatment differs between the two, with more focus on parents for disruptive behavior, more focus on the individual for depression. But then the randomized control trials where these studies are performed are also quite different from community settings, especially, or maybe most importantly in my mind at least, in the ways that some of the factors that are more common in community settings are also predicting poorer response to these treatments. So to apply these evidence-based treatment studies to community settings, there's a few different ways people have done this, but the way I'm going to talk about today is sort of a process of identifying practices derived from the evidence base, or PDEs. I'm going to use this term a lot through the rest of the presentation, so I think it's important to just define it a little bit and talk about it. This process basically tries to identify specific elements of the treatment. So when they have these big manualized treatment, it's sort of breaking it down into like, okay, it's not just parent management training, it's you do psychoeducation, you do praise, you do active ignoring, you do timeout, and each of those is a practice element. And the way determining if these are derived from the evidence base, one way to do this is to just see how often these practices are a part of the evidence-based treatment for a certain problem. So an example of that is like, if every evidence-based treatment for disruptive behavior includes praise, then there's a pretty good case to be made that praise is a practice derived from the evidence base for disruptive behavior. And fortunately for my research, CAMD and Hawaii's Youth System of Care has a process where therapists are filling out what they're targeting in treatment, how much progress they're making, and what practice elements they're using on a monthly basis with their clients, which has yielded this really rich data set of what's happening in this treatment setting. And they're doing that through the monthly treatment and progress summary. Some studies have already been done on some of this data. I'm just going to touch on a few, I think, key points that led to my study. Trina Orimoto in 2014, she was looking at practices which predicted disruptive behavior progress. She found 8 out of 54 in her study were doing that. And she didn't make this claim, so I don't want to put words in her mouth, but when I looked at her study, what I saw is that none of those 8 practices were actually what I would consider to be parent-focused practices, which I thought was interesting. And given this kind of comorbid picture between disruptive behavior and depression, for my thesis project, I looked at whether focusing on disruptive behavior problems was predicting disruptive behavior progress. And I found kind of a counterintuitive finding where the more targets that therapists were endorsing, as far as like focusing on disruptive behavior targets, the less overall progress they were making on those very same targets. Meanwhile, when therapists were focusing on depression targets, youth were actually showing higher disruptive behavior progress ratings if they had a comorbid depression diagnosis. So the picture here is one where, for whatever reason, higher focus on disruptive behavior problems is correlated with lower progress on disruptive behavior, but higher focus on depression problems was correlated with higher progress if youth also had mood problems. So some of the questions through all of this research led to my current study. So given the role that irritability plays in this comorbid disruptive behavior depression connection, and some of the greater parent treatment barriers in community settings, just the increased complexity of clients in community settings, and some of these counterintuitive findings that aren't quite what you might expect as far as like focusing more and using these practices predicting progress, I was very curious whether these practices derive from the evidence base for disruptive behavior, for depression, or for both, because some of these practices overlap in the evidence base, are predicting disruptive behavior progress for adolescent and pre-adolescent youth samples. Some of the kind of specific questions I was curious about is, are these depression practices effective for disruptive behavior? The study can't answer whether they're effective or not, but I was wondering, is there a correlation here where depression practices are correlated to more progress? Similarly, are these disruptive behavior practices effective for disruptive behavior in this setting? Like, is there a connection between using practices for disruptive behavior and disruptive behavior progress or not, which you'd think might not be a question, but with some of the previous findings, I really was wondering about this. And then finally, because these age groups have different evidence bases, is there a difference for adolescent and pre-adolescent youth? So that's just some of the background research that led to this study. I think this is a good place to stop and maybe field any questions about some of this research, a little bit about my study. I'm going to get into the details of my study itself after this, but I'm hoping this can be a time for any questions people might have so far.
Thank you, Dan. Just checking in at this halfway stop point. One question came up from the audience about how do ODD and CD differ from each other?
So I think this is important for this study for a couple reasons, because as I'll talk about as I get into my study, I'm really looking more at symptoms of ODD than conduct disorder. I would say broadly, oppositional defiant disorder is kind of more focused on authority figure child conflict. So the symptoms there are like often argues, often breaks rules, annoys people on purpose. The symptoms are, I would say personally, a little bit more catered to younger youth. Like purposefully annoying is something that I think is harder as a symptom to assign to a 17-year-old, for example. Conduct disorder is really more focused as far as the symptoms in the DSM on like major rule violations. So a lot of the conduct disorder symptoms are also legal violations. And it's a bit less of the kind of emotional dysregulation in the symptoms there. Like, 3 of these 8 symptoms in ODD are really about getting angry a lot, throwing temper tantrums, being quick to anger. And in conduct disorder, it's much more focused on what specific behaviors are you doing? Are you lying? Are you stealing? Are you, breaking and entering? And it gets into that kind of higher level legal violation stuff quite a bit more. One thing I think that's interesting, just as a quick aside about this too, is in DSM-4, you used to not be able to give both oppositional defiant disorder and conduct disorder because it used to be thought of in this way as like, well, if you have conduct disorder, then you must also meet criteria for oppositional defiant disorder. But they did change that in DSM-5, and there's good research behind why they made that change, because that's just, it's not the case that if you have conduct problems, you also have oppositional problems.
Thank you, Dan. Maybe we'll do one more question now, and then we'll save the questions, comments, the rest to the end. Another question just popped up from the audience. Question is, I don't know if you can see it in the Q&A, but I'll read it just in case not. Any highlights or notable findings from Hawaii studies regarding ODD?
Not really. And I think there's a couple reasons for this potentially. One reason potentially, as you'll see, like for my study, I didn't look at ODD diagnoses. I actually kind of avoided diagnosis in general, and I selected my sample based more on if therapists are targeting disruptive behavior problems. The diagnostic data can be a little bit messy in the CAMD data set, so it's hard to make super clear claims about like if this group is, has oppositional defiant disorder or not. Some of the diagnoses can change for youth over time. And I think based on what I know about the research that has been done with this data set so far, people haven't looked specifically at like ODD focused research. So that's my understanding. I don't know if Brad, you have other information, but as far as I'm aware, there isn't anything within Hawaii's system of care that's really looked at ODD specifically.
Thank you. A lot of great questions coming in. Maybe looking like Jamie has a question. Maybe we can save that one towards the end if that's okay, Jamie. Maybe we can just for now we'll take Scott's question, and then if that's okay, let me see. Oh wait. Oh sorry. Wait, Scott, should we? Maybe I'm misreading things. Is that a question for Dan? Should we? What do you think? Should we just proceed with his presentation or?
Sure, that's fine.
Okay, sorry about that. I'm just getting confused. Okay, why don't you go ahead, Dan? Thanks.
Okay.
I'll do a better job of following along.
All right. So now I'm going to get into my study specifically. The participants for my study, I was only looking at youth who received intensive in-home services through CAMD. All youth in my study had at least 3 months of treatment. I only looked at the first 6 MTPS months. I did that because I wanted to avoid like some of the extended treatment episodes that some youth are getting. I did exclude some diagnoses from the sample. I was thinking specifically the ones that I would think would radically change the course of treatment. So things like psychosis, mania, and intellectual disability were excluded. And that left me with 2 separate age group samples. So there's the adolescent youth sample who were aged 13 to 17. There's about 1,200 of them. And then the pre-adolescent youth sample, which was between the ages of 8 and 12. Both of these when they started treatment, that was their age. The measures I used for this study, like I talked about before, I primarily used the MTPS data. That all youth had at least 2 months of disruptive behavior problem treatment focus. So every youth in this sample had therapists endorsing, focusing on either anger, aggression, or oppositional non-compliant behavior in 2 of 6 months at the least. Most of them were more than 2 months. Most of them were more than these 2 targets, but that was kind of the cutoff that I set. The progress ratings, for those who aren't as familiar with the MTPS, range from 0 to 6. So what people do when they fill out the MTPS is they endorse what they're targeting, and then they give a progress rating for that target, and they rate it compared to a pre-treatment baseline. So 0 in this case is deterioration from pre-treatment, so things have gotten worse since it started, whereas a 6 is complete improvement from pre-treatment. I did also use data from the KFIS, but it's not as important for the purpose of this presentation. It's just another thing that I looked at as far as if impairment is playing a role. In order to define these practices derived from the evidence base, I used data from an organization called PracticeWise. PracticeWise is an organization, I don't want to butcher all that they do, but part of what they do is that process of kind of looking through the evidence base and matching practice elements to treatment, and sort of identifying certain practices as derived from the evidence base. I won't get into the details too much here of how I made a cutoff, but I just wanted these practices to be in at least 20% of the studies in the PracticeWise database to determine them as like, okay, this is a practice for disruptive behavior or for depression. I did this separately for both age groups, but as you'll see on this next slide, there is no like solid evidence base for pre-adolescent depression. So I had to use the practices for adolescent depression with the pre-adolescent group. And that yielded these 3 categories for each sample. So this is a long list. I think you're probably not gonna be able to go through all of the different practices here, but one thing I will say about this is the mood category and the both category were the same for both age groups. This both category, again, is the one where these are practices derived from the evidence base for both problem areas. Those are things like social skills training and problem solving. So only the disruptive behavior category ended up being different here, in part because I had to use the adolescent practices for depression for both groups. To look at this data, I did a 3-level multi-level model. The quick summary here is that I'm looking at this data in a nested way, where each MTPS month is nested within a client, and then each client is nested within the therapist that's working with them. I thought this was important for a couple reasons, especially given that therapists are the one kind of completing the MTPS and rating the progress that's being made. And I wanted to account for variance at every level here. I also needed to create some kind of structure for time, because this is a growth model and I'm looking at change over time. And what I ended up with is this kind of R-shaped curve, just because youth are making more progress early in treatment and tend to kind of flatten out with how much progress they're making later in treatment. So these are just some of the nitty-gritty details of the statistics that I use for this. So in order to do this study, I went through a model building process where I added variables for each level in a sequence, and then I removed the ones that were not significant at every step of that building process. I didn't remove the main PDE categories at any point because that's what I was wondering about, and so those need to be in the final model. But I do want to touch on some of what wasn't significant in predicting disruptive behavior progress in both age groups. So at the time level, that's the month level, I created a 4th category of every other practice, basically. So I had these 3 practice derived from the evidence-based categories, and then I put everything else into a 4th category just to see, like, is this predicting progress? And it didn't for both age groups. I also looked at gender and race, both of which were non-significant for both age groups. And then at the therapist level, the only two variables I had for therapists were licensure status and highest degree obtained, both of which were not significant, both of which were removed in the end, the final model. Then for both models, there were two significant predictors, which I think is just worth kind of briefly touching on because it seems, I don't want to say obvious, but maybe to be expected. So time, of course, predicted progress. Youth just tend to make more progress over time. And then CAFIS also did. So the more highly impaired on the CAFIS youth were, the less progress they made, which I think makes sense on the face of it, that more impaired youth just are not responding as much in treatment. So that led to my results for each model, and I'm going to go through them by age group. For the adolescent youth, the mood practices, and again, these are the practices that are derived from the evidence space only for depression and not for disruptive behavior, did predict disruptive behavior progress. And it actually predicted with a larger effect size than the both category, which was also significant. So both the mood practices and the both practices did predict progress, while the disruptive behavior but not mood practice category did not. So I maintained that in the model, but it was not a significant predictor of progress. A couple other variables that were significant for adolescents is that the older youth were, the more progress they were making in disruptive behavior. And then also replicating my thesis findings, the more that therapists were targeting disruptive behavior problems, the less that youth were making progress on those problems. So that led to, this is kind of a quick snapshot of what the relationship between practices and progress looked like. So that orange line is the mood only practices. As you can see, it had maybe the largest magnitude, I think is the right way to put that, of relationship between, like, the more therapists were endorsing these practices in a given month, the higher progress ratings were. Interestingly, though, to me, is that this disruptive behavior only category, not only was it not a significant predictor of progress, but you can't make too much of this. It's not like statistics to interpret this exactly, but I do find it notable that it's actually slightly negative with the relationship that is there. Again, it's not statistically significant. This could just be noise. But what's interesting to me, it wasn't kind of close. Like it's moving in that direction, but it's not quite there. It's actually in this analysis going the opposite way that you might expect. For pre-adolescent youth, the results were similar. The mood practices, again, had the largest effect size in predicting disruptive behavior progress. For the pre-adolescent youth, though, the disruptive behavior only category was a significant predictor of disruptive behavior progress, while the both category was not. In contrast to the adolescent model also, younger youth tended to make more progress on disruptive behavior targets. So that kind of suggests that youth that are between maybe the ages of 11 and 14 are making less progress than youth that are both younger and older than them. And then for this model, treatment length also predicted progress. So youth who had shorter treatment lengths, 6 months or less, made more progress after 6 months than youth who did not, which again, I think kind of makes sense on the face of it. This is another visual relationship for the pre-adolescent model results. Again, that orange line is the mood only practices, had the largest effect size. But then here, both of them had some kind of positive trajectory, but only that red line was statistically significant in this analysis. So I did some follow-up analyses that are too much to really get into today, but I want to touch on them at least a little bit because I took these categories and broke them down into individual practice elements to look at whether certain specific practices were kind of responsible for some of these results. Some of the big picture takeaways in my mind are, first, that praise of all sorts really tended to have a relationship with positive progress. So there's a few different measures of praise in the MTPS. There's like self-praise, which is a mood-only practice. There's parent and teacher praise, and then there's therapist praise. But all of them were showing this positive relationship with progress. I also found kind of a theme that practices more focused on reducing negative behavior were not predicting disruptive behavior progress. So I'm thinking of practices like timeout and response cost, DRO, which is not just focused on reducing negative, I would say, but that's kind of like the active ignoring practice element on the MTPS. Just wasn't showing the kind of relationship with progress that you might expect. And then I think one theme that stuck out is just that adolescent youth tended to have larger effect sizes everywhere, both in positive and negative directions, which I'll talk about a little bit as I get to just a quick summary of this individual part of the study. So for adolescent youth, every single mood PDE predicted disruptive behavior progress on its own. About half of the disruptive behavior PDEs predicted progress in a positive direction. 5 of 7 of the both practices predicted progress in a positive direction. But then 2 of the DBD practices and 1 of the both practices actually were significant predictors of negative progress. For pre-adolescent youth, the picture is just a little bit murkier. So 3 out of 5 of the mood practices predicted progress, 4 out of 12 of the disruptive ones, and 3 out of 7 of the both ones. And then for pre-adolescent youth, none of them were significant predictors of negative progress. So that leads to some of the discussion points that I take away. And of course, we'll have more of a discussion about this, and I'm interested in some of the insights that you all might have. But here's some of the ones that stick out to me, at least from these results. First thing that sticks out is related to this study and my thesis study, where it's just these mood practices are the most consistent predictors with the largest effect size for disruptive behavior progress, which again is like, that's not what you would expect from the evidence base. And one question I have about that is maybe this is addressing irritability. So irritability, like I talked about before, shows a lot of comorbidity with mood problems. Youth with irritability tend to develop depression more than youth who don't have irritability. And it could be that these practices are addressing that in some way, given the overlap between irritability and depression. And I think this is an important point because there's really not much discussion I could find in the literature that looked at like this potential, this possibility. There's this emerging body of research that, okay, irritability is connected to depression, and we're finding it here, and we're finding it here, and we're finding it here. But there's not as much dialogue at this point about like, do these treatments for depression then work for irritability? And especially for these kids that maybe aren't at a developmental level where they can really exhibit major depressive disorder, but could be on their way towards that problem. Like it could be that these practices are effective for them. Another takeaway to me is this relationship between parent-focused practices and progress, again, kind of showing not what you might expect. I think one possibility just in this study in general that I think is really big and important to talk about is that, this isn't an experimental design. And so I can't say anything about causality. And it could be that there's just a correlation here where therapists, when things are going better in treatment, when kids are responding, when everyone's on board, might be focusing more on youth practices and working with the youth. And then when things are kind of going off the rails and there's a crisis and there's a lot of behavior problems to try to sort of stomp down and take care of, therapists might just be working more with parents at that point. And that might explain this relationship between these practices and progress to some degree. That's the kind of like, okay, maybe this doesn't mean very much version, but I think the more interesting thing to me is that this could be because of these, many barriers that families have in this setting to treatment. It could be that in community mental health settings, parents who are under a lot of stress, who are poor, who have their own problems, they just might not be as responsive to a parent-focused approach as youth in the randomized control trial studies. Another takeaway here to me is maybe there's something going on with promoting positive behavior and its association with progress. Again, the possibility of correlation here is something to consider. Therapists might be praising more or using praise more when things are going well, and then might be using some of the punishment kind of focused treatments like timeout when it's not going well, just trying to take care of the crisis. I do think there's some evidence here, like one of the practices that was a significant predictor of negative progress was parent coping, which that makes sense. Like if you're doing parent coping that month, then there's probably something going on that you need to work with the parent to help them cope. And that might be why there's this kind of negative relationship. That said, though, I think there's another possibility here to consider, that youth in community mental health settings might just be in more need of positives. Like, it might be that there's just not many reinforcing positive things going on in their life. And so if you come in and you do activity scheduling, which is a treatment for depression, setting them up with just getting involved in something, even if they don't have problems with depression, they might be responding to that treatment because it's just some kind of outlet. It's some kind of positive. And if you're reinforcing them on anything positive, that could be key if they're so lacking in that in the rest of their life. Last thing I think to consider as a discussion point is how much the evidence base is really aligning with needs in community mental health settings. Given some of these sample differences that I talked about before, it could be like a real consideration for like how evidence-based are some of these practices with some of these kinds of clients. And could it be that with clients who are really heavily impaired, that there should be just more focus on leveraging what strengths exist and really turning to, okay, like this isn't gonna maybe be helpful because of this and because of that. So what do we have to work with here, and how can we kind of maximize that as much as we can? There are some big limitations here. Again, I think it's just really important that hopefully as I talk about this, I don't suggest causality. There is nothing you can really say about causality with this study. It's a correlational study. There is some question for how representative some of these PDEs might be for like the evidence-based treatment version of that practice. So like if a therapist is endorsing cognitive, it's not really clear what that means and how much that maps on to how cognitive work is done in some of these treatment manuals. This is self-report data, so therapists are filling out how much progress is being made and what they're doing in treatment. That said, the MTPS is a valid and reliable measure, so I don't think you can just like kind of toss this out as like, oh, well, it's self-report. You know, these are valid, reliable measures, but there is some potential bias in the self-report. Then finally, one big limitation for this study is dosage is unclear in general. So because the MTPS is done on a monthly basis, it doesn't speak to how much a certain practice is used. So it could be that if cognitive is endorsed on one MTPS, that could mean they spent 5 minutes doing some cognitive work. On another MTPS, it could be that they spent like 10 full hours just really focusing on cognitive. And I had no way to measure that, so I had no way to include that in this study. Some potential considerations for the audience today. I know it's a pretty diverse group of people here, so I tried to think of what might apply to at least a majority of the people who might be in the audience. Again, I think the caveat of just interpreting this with caution is important to put up front. I do think maybe something to take away from this is just considering irritability. Like if the youth you're working with has major problems with irritability, it could be that, you know, they have a deficit with emotion regulation that might be addressed by some of these treatments more focused on internalizing problems in the literature. Like that's, to me, I think a big theory that I have is that emotion regulation deficits might be underlying both irritability and depression, and that could explain the bridge. I don't think there's solid data on that yet, but it's something to consider. I also think considering parent barriers in general is important in community settings. It could be for some parents, you really try to focus on like, okay, what are the barriers here? What is the motivation for treatment here? I know I've worked with people who they don't want treatment. They were referred, you know, by the court system, by the school system. And so they are not there to engage in treatment. And it might be a matter of really problem solving that, even to the point of like, we're not going to jump into treatment with youth yet. We're really going to problem solve with the parent and figure out like, what can we do here and what can we leverage? I also think this is a big question I have personally, is just what do you do if the parenting approach for disruptive behavior is not going to be productive? Like if you're working with a parent who's just not engaged, they're not doing the practices, they're not interested in the treatment, what do you turn to? Because the evidence base right now isn't really informing that. And it's something I think to just keep an eye on. I also think just environmental barriers are important to consider outside of just parents. So barriers like, can they come to treatment? Like, is parent available? Are they working 2 or 3 jobs? Like, anything like that is just important to consider as far as like going in with these evidence-based treatment and applying them, because there could be a way to do that that takes these barriers into account. Final consideration I want to give, though, is just not to throw the baby out with the bathwater here. Like, I am a very strong believer in the parent training approach to disruptive behavior. Theoretically, it makes a lot of sense. You're helping to change patterns of reinforcement. You're reinforcing more positive behavior. You're removing reinforcement for more negative behavior. And I don't want the message from this study to be like, oh, well, that doesn't work, and so we're not going to do that. I still think that this is the first place to turn to for disruptive behavior problems. So with that, I guess I will open the floor up to the discussants and field any questions that anyone might have. Thank you.
Thank you very much, Dan. All right. Now if it's okay, I'll be transitioning to introducing the panelists. Two of our, they're all special panelists, but two of our extra special panelists today are Adam Weiland, MA, and Mr. Weiland grew up in Castleton, North Dakota. He graduated from the University of North Dakota with a bachelor's degree in psychology in 2011 and moved to Honoka'a, Hawaii that same year. Mr. Weiland later attended the University of Hawaii at Hilo's Master's in Counseling Psychology program, and graduated in 2018. His first year after obtaining his master's degree was spent as a therapist for both the therapeutic foster home and intensive in-home programs through Child and Family Service. He has spent the last year and a half working for the Department of Education as a behavioral health specialist stationed at Honoka'a High and Intermediate School. Welcome, Adam. Thank you very much for joining us today. Second, I would like to introduce Reggie Ching, LCSW. Ms. Ching is a licensed clinical social worker who has been practicing in Hawaii for 33 years. In November 2018, Ms. Ching started working with Halekipa as a clinician, providing intensive in-home services for the Big Island's youth. Currently, Ms. Ching is a clinical supervisor for Halekipa's Oahu-based intensive in-home program. For 25 years, Ms. Ching has worked with youth diagnosed with pervasive developmental disorders, ADHD, depression, anxiety, PTSD, and substance abuse across a variety of settings, addressing comorbid disruptive behaviors. Thank you very much, Ms. Ching, as well, for joining us. And as we frequently do, we have the pleasure of having a host of CAMD leadership here. We have Dr. Scott Shimabukuro, CAMD's acting administrator, Dr. Leslie Staven, CAMD's clinical psychologist supervisor, and Dr. Kurt Humphrey, CAMD's medical director. So welcome, panelists. And if I'm tracking, I see Susan has some question. I'm gonna circle back to some of the earlier questions, if that's okay. Sorry, I'm doing my best to keep track of these. Let's circle back to one from Jamie. I'm gonna repost it here. Did I repost it? Did I? Wait, let me hold on. Sorry. If it doesn't work. Oh, here we go. Okay. So we service a lot of youth with a history of trauma and often struggle with stigma related to the disruptive behavior disorder diagnoses, which seems as if it could increase depressive symptoms over time. Is there a benefit to disruptive behavior disorder diagnoses over a trauma-focused disorder, or giving both diagnoses? So we can turn to any panelist answering this, Dan or anybody. So I also put it in the chat, but let's circle back to Jing's question. Yeah, questions or thoughts from folks?
I have some thoughts that kind of relates, I think, to my view of the DSM. So this is very much just my kind of personal approach to the DSM. I tend to be a symptom purist in the DSM as far as like I just want to know, do they meet criteria as far as how it's spelled out in the book or not? And then my interpretation is not really tied to whether they meet this diagnosis or not. So this is just personally in my mind. I tend to give diagnoses if they meet criteria. And if they don't, then I tend not to give it. And I think to me, the benefit of considering a disruptive behavior diagnosis is how it informs treatment and how it's kind of conceptualizing the problem. So for trauma, for example, because I think a lot of the youth that have disruptive behavior problems also have some trauma in their background. But if they were meeting for ODD, for example, and not PTSD, I would definitely want to go with ODD because that would really inform anyone who kind of picked up that file and look through what diagnoses were given, what direction they might go in treatment. Because I do think that even with the trauma background, addressing the disruptive behaviors through this parent approach is probably the most helpful way to address it. So those are my brief thoughts. I don't know if there's a super definitive answer though.
I have a quick comment, just that, I think sometimes we talk about seeing kids through a trauma lens, which is to understand that some of the disruptive behavior comes from trauma. And if that's a major factor, I think it does need to be addressed in some way. And I think it can be less stigmatizing, right? So you can see this kid as an awful little brat, who has ODD, or we can see him as, a kid who's been through an awful lot and really needs a lot of support. And often that will help them get better faster.
Thank you. Other thoughts on this question before we move on?
I was just going to say really quickly in response to Leslie that I fully agree that like disruptive behavior is what I'm interested in research. I really enjoy working with disruptive kids. I have been dismayed at times how much stigma there is around disruptive behavior disorders, even within the mental health field itself. And I forget sometimes that the lens that I have for these kids is very different than how other people might see them. Because to me, it's just like they're dysregulated. They don't know how to meet their needs. And it's just trying to work with them to hopefully meet their needs more effectively and teach them how to meet their needs and then reinforce that and show them that they can get what they want and they can have a good life through a positive route. So absolutely addressing stigma for disruptive behavior, I think is just kind of a national problem.
The thought that I had around it was, sometimes I wonder if I think about things a little bit simplistically or weirdly, but I always try to figure out the why from the diagnosis, because I guess I feel like you can have ADHD symptoms and meet all the criteria for ADHD, but if you have all of that because of your trauma, and because of your trauma you can't sit still and you can't focus and you can, then yeah, sure, maybe the ADHD label does fit for you, but you really have to look at treating the trauma, because that's kind of the why. And so I think for ODD and a lot of other disruptive behavior disorders, like it is great to know whether or not they actually like fit the strict criteria of what the DSM says about those diagnoses, because I think that can help with treatment in a lot of ways. But you also do have to investigate the why, and sometimes it's trauma and sometimes it's maybe more of like a maybe it's like a substance use disorder that's causing that sort of behavior pattern, or the irritability, or and so there's yeah, so I do really appreciate this idea of like what lens are you looking at the kid through, um and I think that does have some bearing on some of these like interesting findings that came from the study.
I also think it's important that what lens you look through will also often determine how you treat. And, you know, enough said.
Yeah, I agree. I feel like kids that have that ODD label are definitely looked at in a different way, even by a lot of times therapists, and that it can be really challenging to look past those disruptive behaviors, and the study really validated a lot of just what I have intuited in my few years working with these types of kids. Is if you're focusing on that behavior, it almost instantly becomes a power struggle. And whereas if you're just building them up, it seems like they respond a lot better, and just showering them with praise. So yeah, it was really validating to see some of those things reflected in your study.
I also appreciated the thought that the need to address from two focus, the parent approach and the child approach. So often in doing IIH work with our families, I work with the parent on a different perspective, addressing behavior interventions, shaping parental attitudes, and then working on the developmental skills that the child needs, especially at the younger ages, where they're not able to even identify their feelings, or so to be able to establish emotional regulation is very difficult for them. So I feel that that two-prong approach is actually vital, because it's the parent that provides the majority of support to the child.
Thank you very much, everyone. That was great. Maybe we can move on to the next question. At the risk of maybe jumping in a little bit too much, trying to do a 2-for-1 here. There's a question from Katie Evans about what are the possible reasons disruptive behavior and depression show high rates of comorbidity, and Susan Rocco also asked something related about a potential factor between the two being common. And I'll put that in the chat right now, and then I'll read Susan's question. Hold on, give me a second. Okay, so I read Katie's question and then on to Susan's one, which seems related potentially. Could a factor between treatment of depression and decreased disruptive behavior be related to increased optimism or a decreased sense of hopelessness? When we talk about non-compliant parents, it always makes me wonder if the therapist is meeting the needs of the parent. So I wanted to throw out these potentially related, maybe they're two, you can answer them separately or whatever, but just wanted to throw this out to the panel.
I think I want to talk about the second part of that question, because it's something I am really interested in. And it's part of, I think, what I talked about with potential takeaways here. Like, I am wondering, for some families, for some parents of kids with disruptive behavior problems, if part of how you should start treatment, depending on the factors, is really just working with a parent to work through the barriers, to meet their needs, to figure out what you can do most effectively, as opposed to just jumping into like the parent training approach. And that's something that I'm hoping that more research kind of examines. I don't want to state too much. I have like a little dream in my mind of like a treatment approach for some of these families that just aren't responding to this approach, as like a step up, where it's like, okay, you know, because I think the default is referring parents to their own therapists, but I am wondering if it's like you as the therapist work with them towards the child's goals, and you really meet parent needs and really work with them extensively until you can set the stage to kind of more productively go into some of the parent training treatment. So I just wanted to touch on that, because that's something that I've had a lot of thoughts about.
I think it's vital to engage parents in increasing their toolbox, not necessarily teaching them how to be a parent, but increasing the tools that they have in their toolbox than are necessary that their child needs. So, and each child is different and comes with different needs, and they may not necessarily have all the tools that their particular child needs at that moment. So being able to increase their toolbox while you're also working on the child's needs, I think is vital.
I guess one of the things I hear about a lot is that parents of kids in our services aren't customers really for any help for themselves. And it's sort of what you were saying, I think, Daniel, about their court order. They're not really there because they want to be there. And it's like, well, just take my kid and go fix them. And that, I mean, I think our field really needs a lot of help getting past those kind of barriers with parents. One thing I just want to say is I think one of the problems about the research is that we've got a total, like really a lot of confounding between who's the main recipient of the treatment and which problem the treatment is for. So, we don't have a lot of parent focused interventions for depression, and we don't have a lot of kid focused interventions for disruptive behavior. So, I think you've kind of implied that part of the problem is if we have parents that don't want the treatment, but the problem is disruptive behavior, we don't have a lot in our toolkit. So we go to the other tools for depression and anxiety or whatever.
Yeah, and that's part of, I think, what I've considered with these results a little bit is maybe that is showing up a little bit, that, for the parents who like, it's just therapists aren't trying to continue to work with them because it hasn't been productive, and they are turning to what they can use. And then it's showing at least some effect compared to just not really getting them anywhere. And I saw your comment in the chat about working with parents with emotion regulation. That's something I've been doing this year here where I'm training right now. Is the focus is really on not just working with kids to help regulate their emotions,
Right.
but a big part of the focus is on parenting emotions and how that gets in the way of like giving time out or giving praise or setting up a rewards plan, like, because that's such a key part of these parent-child conflicts is that parent also gets dysregulated.
Yeah.
And it makes a lot of sense to me to have that be like a vital part of the treatment.
Especially when the parents too have been through a whole heck of a lot of trauma.
Yeah.
And in multidimensional treatment foster care, they work with the regulation of the foster parent.
I'll touch a little bit on the question about the reasons between disruptive behavior and depression. I know I talked a lot about that irritability hypothesis, that maybe emotion regulation difficulties are sort of showing up for both. And to me, maybe there's a developmental element of it, of like how many 6-year-olds really are meeting criteria for major depressive disorder, for example. So maybe this regulation difficulty is just looking different throughout the years. There is some research out there on the so-called failure hypothesis of disruptive behavior and depression, where youth who engage in a lot of disruptive behavior and get a lot of negative feedback and don't succeed in school and don't succeed at home, then develop depression because they are just not succeeding kind of chronically. So that's another possibility or potential factor.
Thank you. Maybe moving on, I think there are two more, at least two more. Keep them coming, folks. One in the official Q&A. I'll retype it here. And then we'll move on to, looks like Roxanne had a comment/question. Maybe this one is a little bit more of a methodological thing for Dan, if I'm interpreting that right.
Yeah, and I'm ready to answer that one.
Okay.
There's 5 bullet points in my project that kind of goes why I picked these 3 targets and not willful misconduct. Some of the reasons are progress correlates a lot more between those 3 than with willful misconduct. So just the rate of growth of progress, it looks very similar between those 3, but willful misconduct kind of sticks out. Willful misconduct also is endorsed at a lot lower rate than those 3 targets. I'm not able to think of all of the reasons off the top of my head, but that was the one target that I was really considering, like, should I be including this or should I not? And part of the reason I didn't is also where that target was showing up with different kids. Like that one kind of skewed a little more adolescent, if I remember right. But yeah, I don't know off the top of my head, but I had, like, I remember A, B, C, D, E. Here's why I went with these 3 and not willful misconduct and empathy, I think was the other target that I was really considering and then decided not to include.
Thank you, Dan. Now from Roxanne, potentially very interested in considerations associated with the family's culture and values, which might interface with parental engagement in therapy to support the positive development and growth in the child. Any questions and I guess any thoughts from the panelists? Greatly appreciated on this one, related to considerations related to the family's culture and values within the larger context of today's presentation.
I have maybe a couple quick thoughts. I am more and more sold on the idea that you really need to identify values to be able to really work with the motivation that your clients have. So absolutely those cultural factors play into those values. And I think they're really important to identify and kind of align with your client with, to especially kind of elicit engagement and treatment adherence.
But I do feel that, as Dr. Slavin had pointed out, when you have families that, despite their cultural values, when they're overwhelmed with a multitude of problems, that often the attitude of treatment comes in that, you know, here's my kid, fix them and then send them back. That can impede a lot of progress. Because there's the concept that they're not bought into being part of the solution.
Other ideas? Oh, Leslie, I saw you unmute.
I just kind of wanted to ask Reggie, you've been doing this a long time. Do you have any hints about things that have helped parents kind of see that this is something that could help them, or, you know, go from that, this is all cure my kid perspective to I'm in it with you?
I usually present families with the concept that, you know, especially I don't have children. And often you'll hear, well, you know, who are you to tell me you don't have kids? And that's why I usually come with the approach, I'm not telling you how to reparent or how to be a parent. I'm just looking to put more tools in your toolbox. And you know, because your child is unique, we're going to add as many tools as possible. I use a combination of DBT, the no drama parenting principles, which I often will help the parent adjust in their attitude in terms of feeling like their child is doing these things just to get them angry or upset them, which when a parent's able to see that this is how the child is communicating their needs, then it changes attitudes, which also changes focus. Often too, in combination with the DBT, I'll use ABA principles of praise, ignoring, catching them. I like to catching them doing it right. Which helps shift the relationship between the parent and child, because you're always looking for how they're doing it right rather than what they're doing wrong. So it changes the focus.
Yeah.
Parents respond to that. Kids respond to that. A lot of I use a very specific teaching loop where it has praise principles and ignoring principles to shape behavior, which, both parents are, and children are very responsive. And you can use it with the parents too in reinforcing and modeling what you're hoping for the children.
Thank you, everybody. Maybe as we're kind of rounding this out, we're approaching the 4:20 mark. I don't see any more questions popping off, which is fine. We'll kind of just circling back to a couple of housekeeping stuff. Maybe I can ask the panelists to potentially gather any closing thoughts or comments while I'm doing this housekeeping. As a friendly reminder, if you signed up for social work CEUs today, CEUs will be based on both your time in the webinar today, looking for 90% attendance at least, as well as subsequently filling out a survey, a feedback survey that will be sent to your email that you use to register. So please be on the lookout for that email. Also, if you're here and you registered in any regard, whether or not you're looking for CEUs, we're always looking for feedback on that feedback survey. So regardless of whether or not you want CEUs, please, we value your feedback. So if you would consider filling that out, that would be great. And on that, any closing thoughts, comments from anyone? We can kind of go round robin if we want on the panelists. Or not. It's up to folks, but as always, we really appreciate your time and would love any closing remarks.
I guess I just wanted to touch on family engagement and how even if the families aren't necessarily looking to be part of the therapy, like even just touching base with them, finding what time works for them for a phone call, and just validating their struggles, their frustrations, and then kind of finding ways to, look for positives in their relationship with their kids. And it's been really helpful, not only for I think the parents are really, really appreciate it, but also it really helps with my rapport with the kids. I really, I thought this was a great study, and again, the results really kind of helped. They were validating to me, I guess, to see some of those results and some of the things you focused on. So thank you.
I was trying to think of something intelligent to say in the realm of like how with medication management for the treatment of disruptive behavior disorders, I feel like there's something similar that happens where like there's not really like a great medication that really helps kids be well behaved and sit attentively in their chair and do exactly what teacher, parent, what everybody asks of them, and like it doesn't exist. But I mean, to whatever degree medications do seem to help with that, it might be because there is some kind of overlap where it's maybe that antidepressant that you're giving for the disruptive behavior disorder, maybe it's not really helping with that per se. It's helping with the irritability and the mood symptoms and yada, yada, yada. It's helping the child to be less, impaired by those things and more able to attend to what parent is saying, or, something like that. And similar for like maybe an ADHD medication that might be used for a kid with a disruptive behavior. It all seems to correlate with like some other things that might be kind of impairing, I think. So I don't know. I think I might need a little more time to figure out exactly what I want to say there that is kind of in the same realm of what we're talking about today.
I just wanted to say, great job, Dan. It's really exciting, I think, for us in CAMD to see our data utilized in such an interesting, thought-provoking way. And, there's a lot of blood, sweat, and tears that goes into filling out that MTPS, and now our new progress notes every time. But when we get, we reap this harvest from it, and it's really helpful. Thank you. And this seems like it would be a great job talk, by the way.
Well, Dan, when you apply to work at CAMD, you know what talk to give. You can give that. You can give this talk. It's a CAD talk. Any other closing thoughts before we wrap it up? Seeing a lot of thank yous. Yeah, thank you very much, Dan. Thank you to all of our panelists.
Thank you so much. That was great. I can't wait to
Dan?
be able to spend more time with your slides and things.
All right. Thank you very much, everybody. We'll wrap it up a few minutes early. Have a great afternoon. Thank you very much. Bye-bye.